What we're going to do today is just a clinical review of BPPV. It's a great topic for me because a lot has changed over the years. And just a little bio of me, I graduated as an osteopath in 1998, and pretty well everything we're going to go over here has been published and discovered since 1998. So this is all stuff that I've had to learn after leaving uni. A bit of background. So we do, we've got a few specialties. We're an osteo clinic, and I've just got a little picture of us there. We're just up by the Baker's Delight in the Queens Road shops. And so we've done BPPV training and management there. We're a registered post-concussion provider with Complete Concussions, which is a Canadian educational group, and so we're registered with them. And we've done a whole stack of training around headache and migraine treatment, largely based on manual therapy interventions with that, which is largely our bread and butter. And so that's just basically saying the same thing. That's the clinic. Alrighty, and the point of today is to review BPPV and its types. Prior to sort of doing this training, I wasn't aware that it's really hard to say, BPPV does have 5 different variables. And one of the things which we constantly see, because we see quite a bit of this, is that people come in with the Brandt-Daroff exercises. So I just wanted to talk about that briefly and just give an update on what the literature says about that. And then just get into the BPPV, just looking at the Dix, Hall, Pike, and the Epley manoeuvres. The supine roll, which is for a horizontal canal, which we'll get to in a sec. And then just to contrast to vestibular migraine and cervical spine involvement, because that is the other super common type of dizziness that we're going to be seeing in in private practice. Alrighty, so just lost our slide. Okay, so just quick review. So BPPV is where we have the utricle here in the middle ear, and I found this little picture online, and the utricle, if we can, not really show it myself, but the utricle has little, once you go back, maybe if I stop sharing the screen, there we go. The utricle has, all right. Now, can you see me? Can you see me now? Or can you only see the screen?
We can see you, not the screen.
So yeah. It's got little cilia in the utricle, and it's got a little bit of calcium on each one of the cilia, which is what this picture is. Yeah, so we can just go back to the PowerPoint now. Hey, and we're working. All right, which is this little close-up here. So you've got little bits of calcium on these little cilia, and they naturally just fall.
Cameron, I can't see your PowerPoint there, sorry.
Oh. We're into Zoom. Share.
You have to reshare. There you go. We've got it now.
Thank you, Oliver. That was very helpful. All right, let's try again. All right, so we've got this utricle, and we've got cilia, and this little picture here with the bits of calcium, and these bits of calcium called otoconia should just naturally drop off and reabsorb into the utricle. And they don't know exactly how it all happens, but that's the gist of it. They do naturally fall off, but for some reason, and there's lots of theories about, previous traumas and that sort of thing, they come, hopefully you can see my arrow, but they somehow don't stay in the utricle, and they can drift backwards into these semicircular canals. And by far the most common is the posterior canal, because it goes down. And so gravity will tend to keep them down, and they will tend to get in this posterior canal here. But as you know, there's also a, well, I think it's not three-dimensional, but I think that's the horizontal canal, and there's the vertical canal. And so I'm just going to jump to the next slide. So the posterior canal BPPV is 75% of the time, which is the vast majority. But 25% of the time we will be getting a horizontal canal. And as I said there, just in the notes, it's got a variable in that the patient, instead of saying when I just turn over in bed or look down, I get dizziness, it has this variable that when they're standing up and they say I turn my head, I get dizziness, which will give you a in the case history will give you an indication that it's the horizontal canal going on. And really rare, I've never seen one, but apparently the superior canal can also get the crystal going into the superior canal, or the otoconia, if you want to be fancier. Okay, so reviewing the symptoms. So importantly, symptoms last for less than 2 minutes. So to differentiate it from a lot of other dizziness, if we're getting seconds of dizziness initiated by turning head, the classical thing, as I just mentioned, is they say I was in bed and I turned my head, or I got out of bed and I got sudden intense dizziness, usually spinning, and it lasted for 30 seconds and then it stopped. And they probably still felt pretty crappy afterwards. There's kind of like a sympathetic irritation afterwards, but the spinning and the intense vertigo lasts for less than 2 minutes. And that's the key finding for BPPV. And so it's just got it there. So when they're still, they're not dizzy. And there's no nystagmus when they're resting. So we did a previous talk on the Hintz exam. The Hintz exam is where we're differentiating between vestibular neuritis and stroke. And one of the key things is that there is a resting nystagmus for those conditions. If we've got a nice benign BPPV patient who sits there and they have no nystagmus, and if they look to the sides, they also have no nystagmus. All right, so just a couple little key things there which can really clearly differentiate that we've got a nice benign BPPV. All right, so one of the common things people come in with is they say they looked online, or sometimes they had a doctor say, hey, just take these exercises and just do them. And they're called the Brandt-Daroff exercises. Yeah, they kind of look like this. You turn your head, you lie one side, you turn your head, you go to the other side. And in my training, in my BPPV training, we were taught that the Brandt-Daroff is a habituation exercise. So if you've got long-standing vertigo, that the Brandt-Daroff can be used to try and habituate and get used to vertigo. And it's not really a BPPV exercise. However, a lot of people get given it as a BPPV exercise. So I jumped online, and this is the RACGP has this as a handout. It says, well, it's simplified for patients, but benign positional vertigo, to do the Brandt-Daroff exercises, and these exercises should be performed 3 times a day. So it's being recommended at a reasonably high level. But if we have a look at, this is from February last year, effectiveness of the Brandt-Daroff exercises, a systemic review. Just highlighted here, Brandt-Daroff exercises do not significantly reduce symptoms or promote recovery in people with posterior canal BPPV, which is our main one, compared to other interventions such as the Epley and Samont. So just to be clear, it's not saying that it doesn't work. So if we go to 2018, comparing Brandt-Daroff to the Epley, did we have another one in there? So modified Epley. Recovery rates. Oh, it's 3 weeks. That's where the 3 is. Okay, so it's got the recovery weeks after 1, 2, and 3 weeks. 76 up to 100 for Epley and 64 to 100 for Brandt-Daroff. So this particular study said that there was no difference in the long term, which is interesting. And I think this is probably a nice middle ground. This one's from 2018, and they compared 3 groups: the Dix-Hallpike, the Samont, which is kind of a variation of the Epley, and the Epley. And what they found is that the Epley had a 90% resolution. The Samont had a 73% resolution, and the Brandt-Daroff had a 50% resolution. So the Brandt-Daroff exercises can work, but they're about half as effective as doing the Epley. So the recommendation was that the Epley manoeuvre was found to be the best choice, and Brandt-Daroff should be the least preferred in treatment with patients with posterior canal BPPV. So I just wanted to cover that because it's a thing that we see a lot, and it's not it's been shown to not be the best exercise, and much better way to do it is to differentiate whether it's a posterior canal or a horizontal canal, and either do the Epley if it's a posterior canal, which is 75–80% of the time, but on the off chance that it's a horizontal canal, then there's I think we've got 5, I'd have to actually count, there's 5 different variations on horizontal canal, and so we could do a workshop on that, but it would take a day. So for the sake of this particular presentation, I'd just say you could just refer that one to us or your vestibular physio of choice, and we can sort that out, but we can certainly deal with that here. We do that on a weekly basis. All right, so which brings us to the Dix-Hallpike. Now, the Dix-Hallpike is the most, we're looking for the posterior canal here. So we say test for the posterior canal, which is our most common. And you may or may not be familiar, but the patient's seated, they lie back, and their neck is extended and rotated. We do one side, then the other side, and we are looking for nystagmus. The nystagmus will be a torsional, which means that it's got a vertical and a rotational component put together. And we're looking for one side to be really bad and the other side to be, theoretically, it doesn't have anything, but most of the time that they have a little bit on the other side as well. So what we're going to do is we're going to jump to, I was saying to Tiana, this is if you saw my previous video, my favorite YouTuber for anything vestibular is this guy, Peter Johns, who's a emergency physician. I think he's retired now from Canada, and he has an elaborate selection of dizziness videos, and they're a fantastic resource should you want to get more information on this. So we're just going to look at the Dix-Hallpike. So we have the patient seated.
Here's an example in a normal volunteer. Could have gone a little quicker, perhaps. His head is turned 45 to the left. He's 30 degrees extended off the edge of the bed. I'll hold up his eyelid to see if I see any nystagmus, and I wait about 15 seconds or so. If I don't see any, I'll return him to the seated position. And often, if they are going to have a positive Dix-Hallpike on the other side, they often will have a little bit of vertigo when I sit them back up, and it doesn't last very long at all. And I wait for them until they're settled, and then I go ahead and I test the other side. So now I'm testing the right ear. The downward ear is the ear that you're testing. So again, could have gone maybe down a little faster, especially in a young, healthy person. Head extended 30 degrees, turned 45 to the right this time, and observe for nystagmus.
All right, so there's our Dix-Hallpike, and I think it's if we're talking at GPs, it's a really easy thing to do to confirm a diagnosis, is just to get the patient to sit up and drop them down, extension and rotation, and look for a positive sign. And so the positive sign is going to be a torsional nystagmus. And thanks again, Peter Johns. We're just going to have a look at an example of
when
a
she's placed
positive
in the
sign.
Dix-Hallpike position, nothing happens for the first 3 seconds, and then
I'm dizzy.
you can see it there.
I'm very dizzy.
She becomes very vertiginous and has vertical upward nystagmus with a rotatory component towards the downward ear, which is the left ear. It lasts around 15 seconds. This is sort of gone away now.
Yeah.
In slow motion, you can see the upward movement of her pupil, as well as the rotation of her eye, where the upper poles are beating towards the left ear, the downward ear. This is, again, a classically positive Dix-Hallpike test and diagnostic for posterior canal BPPV.
Alrighty, so there is our Dix Hallpike. So really easy, really quick thing that you can do with someone you suspect of having BPPV. Now we're just going to move on to now if you did find a positive and you wanted to treat it, the technique of or maneuver of choice is the Epley maneuver, and so we can quickly do that. If you don't want to do the Epley, of course, you can just refer that on down the street, and we can of course do this as well. Usually in these cases, there's a little bit of cervical stuff as well, which we'll also take care of. But if they are acute, it's that the Epley, as you saw the evidence, the Epley should fix 90% of people. And so if we just sort of have a look at what the Epley would look like, here we go. Once again, thank you, Mr. Dr. Johns.
The right ear Epley is with the head turned 45 degrees to the right and the head extended 20 to 30 degrees over the edge of the bed.
Okay, now I'll just jump in there. So the positive Dix Hallpike is the first bit of the Epley. So if you've done the negative side of the Dix Hallpike and then you get the really positive side, you can actually just go straight into the Epley maneuver from there. You don't have to sit them up. You can just go straight into it. And as you can see there, we're now in the end point of the Dix Hallpike that we just saw. If you wanted to do the Epley, then we would just do this.
The next position is the negative Dix Hallpike side. While maintaining neck extension, rotate the head 90 degrees so that the left ear is now down. The third position is to continue to rotate the head 90 degrees or more in the same direction. In order to do this, you must have the patient turn on their side. Having the patient look straight down is also acceptable. As you return the patient to the sitting position, ensure to keep their head turned towards their downward ear. Leave the patient in the seated position for 15 minutes or more and then repeat the Dix Hallpike test on the side that had been positive on the initial test. A successful result is when the patient does not experience vertigo and no nystagmus is observed. If the repeat Dix Hallpike test is still positive, repeat the Epley maneuver, ensuring that you have waited long enough between position changes.
All right. So just quickly, a couple of notes on that. So what will happen is you will bring the patient down into the first bit, and they will go, "Well, I'm spinning," and you'll see the nystagmus. Then the nystagmus will stop. And so what you want to do is just leave it for another 30 seconds and just make sure those otoconia have settled into their new position. Then we turn to the next bit, and sometimes they get a little bit of nystagmus again with the next turn. Wait for that to finish. Wait another 30 seconds so all the otoconia have settled, and then you bring them onto their side. Sometimes they don't get very much for this last bit. And once again, keep them there. So if they do get any dizziness, keep them there for at least 30 seconds or so. Different things will say different things. Sometimes they say a minute. And yeah, so I'll probably leave it closer to a minute in each position. And then you just sit them up again. You've seen this one that some of them do say to keep the head flexed and rotated to the same side. Peter Johns in his videos doesn't say that, and they say to keep it there for another 30 seconds or so. When they sit up, they will often get dizziness again, and I think it's that last little bit of the otoconia coming out will occur at that place, and because they will quite consistently get the dizziness coming on in that last bit. And you're done, and that's your Epley maneuver. So as Peter John said, so yeah, I mean, you'll get differing views on this. Some people will just say, just leave it and send them away and recheck them in a couple of days. He was saying to, depending on which one of his videos you watch, he'll say leave it for 10 minutes or 15 minutes and then come back and redo the Dix Hallpike and make sure that it's positive. So you can manage that depending on how much time you've got for your appointment, and whether you can leave that person for 10-15 minutes, go see someone else, come back. That's just a time management issue, but that's the basic Epley maneuver right there. You can get people to do it themselves at home as well, should you think it'd be beneficial. All right, now sometimes you'll have all of the signs of BPPV, and you'll do the Epley and nothing will come up. It'll be negative. And what most commonly will be the case is they will all have a horizontal canal BPPV. And so what we want to do is there is a second test called the supine roll test. And let's just go to the video because the picture says 1,000 words. And it's...
Perform the supine head roll test. Have your patient lie supine on the treatment bench and bring his head into 30 degrees of flexion to align the lateral semicircular canals in the horizontal plane. Then quickly rotate 90 degrees to one side and observe your patient's eyes for nystagmus, which usually has a latency of 5 to 20 seconds and fatigues within 60 seconds after onset. After the nystagmus subsides, or if no nystagmus was elicited, the head is then returned to the straight face-up supine position. After additional elicited nystagmus has subsided, the head is then quickly turned 90 degrees to the opposite side, and the eyes are once again observed for nystagmus.
All right, and that's it. So basically, you want a pillow under their head, so their head's at 30 degrees, so a little bit flexed, and you turn it one way and have a look if there's nystagmus. Wait for at least 30 seconds or so, see if anything comes on. Turn it the other way, see if nystagmus comes on. Sometimes you got to look carefully, you've got to look quite closely. And the nystagmus should be horizontal. Oh, there we go. I've got it here. Let's just have a look.
In this lady, when her head is turned to the left side, she has purely horizontal nystagmus beating towards the ground. So this is geotropic nystagmus. When her head is turned towards the right, the nystagmus is more intense in amplitude and frequency. So the nystagmus on this more intense side is pointing towards the affected ear, which is the right ear.
All right. So that's our other tests. So the two basic tests, if you just want to diagnose BPPV, is that Dix-Hallpike, and if the Dix-Hallpike is negative, then you check the supine roll. Dix-Hallpike will have that torsional nystagmus. The supine roll will have the horizontal nystagmus and will indicate the horizontal canal. Now, as I said, where there are techniques, there's a Guffoni technique. I just put it there, first published in 2001, just to point out that, you know, I finished in 1998. So depending on when you finished uni, all of this stuff is very new, which is why it's not really well known. It's all just sort of coming out in the literature, and it hasn't really got into the mainstream teaching as far as I can tell yet. And particularly people who have been out for a long time in practice would have had to have done this as a postgraduate study. So that's the gist of it. And if you get any of the horizontal canal stuff, you can refer that to us and we can do the repositioning for that. If you really want to know, I can take you through them all, but it would take a little bit of time and a bit of explaining. Now, just to chuck in here, vestibular migraine. I've put cervical spine there because we're an osteopathic clinic, and so whenever we have migraines, we have an associated upper cervical component, which we like to scream to the world and let everyone know. But vestibular migraine is very common, and depending on the statistics, 3% of the population will get one a year, or almost 3%, which, if it was up there, it would actually be the most common cause of vertigo, more common than BPPV. Once again, first described in 1999 after I graduated. So once again, there was no vestibular migraine when I was going through uni, and it's a very new diagnosis. It wasn't really recognized previously as such. Differentiator lasts minutes or days. So if you remember that first slide, BPPV only lasts for a few seconds, related to head movement, intense, and stops. Definitely less than 2 minutes. Vestibular migraine can look like that, but generally speaking, it lasts a bit longer. It will be brought on by head movement, but everything is aggravated by head movement. If someone has a cerebellar stroke, it will also be aggravated by head movement. So vestibular migraine generally lasts a little bit longer, but standing still, it's kind of still there. It's not as intense for a BPPV, and then sort of goes to kind of nothing. It's a little bit more consistent. And And in terms of clearly diagnosing it, what they say is there should have been previous migraines. 30% of them will not have a headache with it. And it's common in women in their 40s. Hang on, just pop our PowerPoint back up here. There is a diagnostic criteria, and they say at least 5 episodes. And I think that the gist is there is they're trying to differentiate between a TIA. And so if someone's had a history of migraines and they've had this at least 5 times, then it's pretty safe to say that it's a vestibular migraine. So that they've got a history of migraines. Half the migraines have vertigo, and will have other typical sensitive to light, sensitive to sounds, the aggravated by exercise type migraine symptoms. And it doesn't sound like another cause of vertigo. So yeah, obviously rule out other causes of vertigo. So we see this a lot. Sometimes you seem to get BPPV and vestibular migraine. The vestibular migraine in some of these testing, it's kind of positive on everything. It's like you do the Epley, you kind of get a positive one side, you get a positive the other side. To do the supine roll, that's a little bit positive. The other one, oh, it's not so bad, but it's you get these vague, everything's kind of positive, and responds really well to cervical treatment. Depending on whereabouts their problems are. So yeah, there's my thing. So migraines will always have that upper 3 cervical involvement, very treatable with osteo, especially for prevention of headaches and migraines. And I just chucked in a couple of others just for some differential, just to reminders. Meniere is 10 times less common than vestibular migraine. That was a good stat. So either tells you how rare Meniere's is or how common vestibular migraines is. But they will be dizzy. It will not be intense. I turn my head in bed and then going away. And it will also have ear, oral fullness, tinnitus, hearing loss, all those other symptoms. And of course, the TIA, which I'm talking to doctors, so you guys are all going to know a lot more about that than I do, but you've got your ABCD2, etc. And I'll leave that with you. But once again, it's a TIA is not going to be, I turned my head and got intense vertigo and then it stopped. I think it's got to have a score of 1. It's got to be, you guys will have to answer that one. But it's the longer it's been going, I think it's 30 minutes and 60 minutes to actually rate a score on the ABCD2 rating. So if we have short, intense vertigo, that's not ticking a lot of boxes for TIA. But I'm not going to tell you how to handle TIAs because you guys are the GPs and I'm not. So yeah, so just that's once again what we do there. Any questions, just let us know. But that was just a bit of an overview from I tried to make it kind of clinically relevant for like a standard sort of GP kind of clinic. Any questions, of course, just yell out or let us know. And any BPPV you would like to not deal with, feel free to handball them across, as well as, of course, headaches, migraines, post-concussion type work. We do a lot with that. And I will be doing another talk on review of modern migraine theory, which has changed a bit in recent years, and particularly in this year even, and post-concussion, which has changed enormously in the last 10 years. A lot of research has come out on concussions and the correct way to handle concussion recovery and what to do with it. Fantastic. Alrighty. Well, thank you all for paying attention.